Good afternoon, everybody. We're going to start the free paper session, TANPSYCON 2022. The chairpersons for this session, Dr. Kumanan. We welcome Dr. Kumanan, retired head of the Department of Psychiatry, Madurai Medical College, and immediate past president, TNIPS. We also welcome Dr. Deep, senior psychiatrist, Apollo Hospital, Madurai, and is also the chairman for the Top Kids Foundation, Adolescent and Child Guidance Counseling Center at Madurai. We welcome you both, sir. So we'll start off with whoever presenters are available here. And
do you have the list?
I have the list.
General instructions before presentation of your papers. Each individual candidate will be allotted 5 minutes for the presentation. Presentation should be crisp and don't exceed the time. And we'll have a 2 minutes breakup session for any questions. And the timer will be there for your convenience.
The first presenter, Dr. Yoga Kritika. You can start.
Good afternoon, everyone. My topic on paper presentation is prevalence of psychiatric comorbidities in young adults with acute coronary syndrome. So acute coronary syndrome, it's a leading cause of mortality and morbidity worldwide, amounting to about 32% of death globally. And about 5% of the adult population is suffering from depression globally, making it the leading cause of disability, contributing to global burden of disease. So presence of a psychiatric illness in an individual is not just a risk factor for developing cardiac illness, but it also affects the prognosis of the recovery from an episode of acute coronary syndrome. So though young age MI have an insignificant coronary artery disease than that occurring at an old age, the mortality rate for a young female is higher than the present in the males. The first episode of depression predicts a short survival after MI than the recurrent episode, and high anxiety can cause a risk of recurrent MI by 9.3-fold. And hence the impact of these comorbidities in young adults, it needs to be assessed, addressed to improve their treatment outcome and prognosis. So the aim of the study was to find the prevalence of psychiatric comorbidities among the young adults with ACS. The objectives were to identify the presence of the comorbidities like depression, anxiety, PTSD, substance use, especially alcohol and nicotine, among these individuals, to assess and quantify these factors, and to identify the variations in the prevalence of these factors among the males and females. So methodology, it's a cross-sectional study conducted at the Department of Cardiology by Department of Psychiatry, GRH Madurai, conducted for a period of one month. So the inclusion criteria for the study were the adults diagnosed with acute coronary syndrome who were admitted at Department of Cardiology. Criteria for ACS being ECG changes showing ST segment elevations and/or elevated cardiac enzyme CPKMB, and age criteria was kept as 18 to 40. They came for the review at third month after MI. The exclusion criteria being known cases of psychiatric illness, physical comorbidities other than diabetes and hypertension, and a recurrent episode of ACS. So around 41 patients who got admitted were included in the study, and the following tools were used, that is hospital anxiety and depression scale, perceived stress scale, PTSD checklist for DSM-5, work and social adjustment scale to note the impairment, and alcohol use disorder identification test, and Fragestorm nicotine dependence test. And these were the tools I've used. And the results obtained were analyzed using the trial version of SPSS 25 software. So among the population, about the majority of the population belonged to the age group of 36 to 40%, and the most of the population belonged to, they were male sex, around 85% of the people, and majority of the people, they did not have any physical comorbidities. And the factors analyzed using t-tests had a significant higher values for the females than males. And these were the ANOVA, one-way ANOVA results. For the audit score, they found to be significant association with these factors for those who had a low risk pattern of drinking. And for the Fagerström nicotine dependence test, those who had a low dependence pattern were found to be having significant perceived stress and work social impairment. And these were the scores that we got using these scales. More than about 43% of the people had an abnormal score in HATS, and more than about 51% had abnormal score for depression, and 64% had a moderate perceived stress, and 48.7% had a work social impairment. And the substance use, it was high among these people, that is especially in nicotine dependence, 48.7% had, and the audit score, it was a high for they were having a harmful risk drinking pattern. And Carl Pearson's correlation values were used to analyze the correlation between these factors, and all the factors positively correlated. So acute coronary syndrome and depression, they independently add on to the mortality and morbidity of the individuals. So the study was in line with the previous studies. They had gender variations where the females had a higher, significantly higher scores than the male, despite having a less or no substance use. And in the previous, escitalopram has been found to be potentially reversing the increased pro-apoptotic pathways, and it was also found to be improve the mental stress-induced MI. And one more thing is the substance use pattern has been found to be a variation in this study, and the variation can be associated to the differing pattern of substance use before and after acute coronary syndrome. None of the patients had a significant correlation based on the age or age criteria, and no significant correlation was found no significant population was found to have PTSD symptoms. So the limitations of the study is the cross-sectional study. Limited number of patients were only taken, and there was a disproportionate gender distribution. And severity of the disease, duration of hospital stay, and severity of the symptom correlation was not done, and the intervention and follow-up was not done.
Yes.
This is the last slide. The conclusion, it is just another exemplar to emphasize the need to address the co-occurring psychiatric comorbidities in these patients, especially the young adults with acute coronary syndrome. The principal findings were the prevalence is found to be nearly in half of the individuals, and the females are at a higher risk, and especially the prevalence of the comorbidities in those who are trying to cut down their substance use, and screening for psychiatric comorbidities and addressing them should be considered as a part of their routine stabilization procedure.
Okay. Just two questions from me. You said short survival after MI. What do you mean by that? And why did you select this PTSD scale for that? Did you predict or you guessed patients the MI will have PTSD during assessment along with the other scales? Your hospital anxiety depression, you have selected specific PTSD scale. Whether you selected or you applied the scale after getting all the symptoms and the findings, or you just previously you had decided?
Sir, in the previous studies also, they have they have analyzed that PTSD was also one of the psychiatric comorbidities co-occurring, sir. That is, so that's why as a routine procedure to screen for PTSD, and as for short survival, especially the mortality following an MI is, that's what I mean by that, sir.
So you have to be very clear. Short survival means patient died after some time after recovery.
In a follow-up study, it was referenced.
They survived for 15 days or 10 days and they expired. Now, what do you mean by short survival?
Compared to those who had no co-occurring comorbidities, those who didn't, they have a better prognosis. That's what.
Short survival, what is your criteria? Short na how short? 1 month, 6 months, 1 year. What is the short? What's
6
the duration
months criteria, sir,
6 months
because
criteria.
usually these comorbidities are higher during the 3rd to 6 months of period, sir.
Anybody from the floor? Any questions?
Mic irka? That can be sent into the audience. Somebody.
So it was a nice presentation anyways. From my side, you are assessing the psychiatric comorbidities in patients with acute coronary syndrome, right?
Yes, sir. young acute coronary syndrome.
Okay, right. So regarding the psychiatric comorbidities, you mean a syndromal depression or depressive symptoms? What you're trying to assess?
Sir, syndromal, sir.
Syndromal depression.
Yes, sir.
So very specific to syndromal depression, what rating scales you have been used?
Sir, we could have used HAM-D, sir, but since HATS was better to assess both anxiety as well as depression with using a one tool, I thought we could be easy to administer.
Okay. So, so you're trying to evaluate only totally of anxiety disorder.
Yes, sir, mostly because the psychotic symptoms in MI patients or ACS patients has been found to be of low prevalence, sir. So majority of the previous studies are also have said like only the anxiety spectrum disease and depressive symptoms have worsened the prognosis. So that's why.
You mean depressive symptoms and anxiety symptoms are worsening the prognosis, not a depressive disorder or anxiety disorder?
Depressive disorder studies are also there, sir.
Okay. Thank you.
One more question allowed. Your time is up. Thank you. Thank you. You can.
Thank you,
The
sir.
next candidate.
Yeah, the next candidate for the free paper is Dr. Vijay Lakshmi.
Good afternoon, everyone. My study paper is on internet addiction among general population. It's a prevalence study. Introduction. Internet addiction is a pathology, a disorder, and overuse of this technology, including a wide range of behavior and impulse control. It negatively affects the way of living and is able to change the personal perception of space, time, perceptual levels, and produces neurobiological abnormalities. In DSM-5, it is classified under condition for further study. Aim of my paper is to determine the gender differences on internet addiction, to find the age group which is more involved, and to find the influence of educational status and socioeconomic status on internet addiction, to estimate the prevalence of internet addiction among general population. Methodology, we included general population from 16 to 14 years of age. It's a cross-sectional analytical study with a sample size of 200, and it's a 1 month period of study and convenient sampling. We included general population from 16 to 45 years of age and those who are willing for the study and who have smartphone. We excluded age less than 16 years of age and more than 45 years of age, and those are not willing for the study, and people with any physical or psychiatric illness. We use tools. First one is a semi-structured socio-demographic proforma and Young's internet addiction scale, which was most commonly used, and it is a self-reported questionnaire. It is translated into Tamil, and we standardized with it had a Cronbach's alpha of 0.7, which suggested good internal consistency. My socio-demographic characteristics, it included name, age, sex, religion, education level, marital status, locality, employment status, living arrangements, and financial dependency, and socioeconomic status. Socioeconomic status is based on modified Kupaswamy scale. This is a Young Internet Addiction Test questionnaire. It had 20 questions, and each item is rated on 5-point Likert scale. It's ranging from 0 to 5. Total score is based on the sum of the ratings, and maximum score is 100. And if score is between 0 to 30, it is normal level of usage. Mild is between 31 to 49, and moderate is between 50 to 79. Severe level is 80 to 100. Statistical analysis done using SPSS 16 software, and this is a Tamil questionnaire, translated version. Age-based distribution, we had 23.5% of them in less than 20 years of age, that is between 16 to 20, and 30% of them is between 21 to 30 years of age, and 27% from 31 to 40 years of age. More than 40 years of age, we had 19.5%. Internet addiction scoring based on age, we had mean value that is in less than 20 years of age, the average of mean scoring was 39.51, and from 21 to 30 it is 34 point. This is internet scoring, and 34.70, and 31 to 40 it is 33.33, and more than 40 is 28.36. Gender wise, we had 51% males and 49% females. And based on internet scoring, males had an average mean value of 37.55 and females 30.77, which is more in males. Educational status, we had 34% of them who have completed the diploma. I'll go to internet scoring. 10th standard, up to 10th standard, the average mean value is 32.71. And diploma holders, they had average mean score of 38.68, and graduates 34.55. And PGs and professional, it was 35.24. Socioeconomic status, we had 46% of them in the lower middle socioeconomic status, and 37.5% in the upper middle socioeconomic status, and more or less 8% in the upper and upper lower socioeconomic status. Average mean value scoring, the socioeconomic status is 40.31. Severity, we had 42.5% that had a normal level of usage and mild level, 14.5% had moderate level of internet addiction, and 0.5% in severe level. Gender-wise severity, we had 28 of them, 57 of female had normal levels, and 55 had mild level, 19 of them had moderate level, and one individual with severe level of addiction. And based on age, it was p-value was found to be less than 0.001. It was found to be significant, and in educational status, it was found to be less than 0.001, which was significant, and based on socioeconomic status, it was significant. This this study attempts to determine the severity of internet addiction among general population, general differences to find the age group more vulnerable, and influence of education and socioeconomic status on internet addiction. Prevalence of mild internet addiction was found to be 42.5%, moderate levels were 14.5%, and severe internet addiction was 0.5%. This suggests that males tend to use more internet than females, and in a study by Choi et al. In 2008, internet addiction was more common in males than females. However, in internet usage levels in females have increased in recent studies. Young population from 16 to 30 years of age were using internet more than elder population. There is an influence of higher educational status and socioeconomic status on internet addiction. In a study conducted by Yadav et al., younger students were more inclined towards internet addiction, as young age students are more enthusiastic to explore and surf more on the internet. Lee and McKenzie et al. Found relationship between lower socioeconomic status and internet addiction. Contradictory findings were also found regarding socioeconomic status and internet addiction. We found that, male gender from 16 to 30 years with higher education and socioeconomic status are more addicted to internet. Excessive usage of among young population may be due to easy access towards smartphone, affordability, and increased exposure. It has natural risk for addiction, and the prevalence of mild level is 42%. As per the individual, that do not cause interpersonal, social, occupational impairment. It is not considered as a major concern by the individuals and is similar to normal levels of usage. Limitation is sample size is small, social desirability on cross-sectional study, and lack follow-up. Being aware of how to use the technology carefully is essential, and young people are ignorant of the time consumed on the internet. Prevention may be one of the useful methods to avoid addiction. Thank you, sir. These are my references.
Yeah, any questions? It's open for discussion.
So internet addiction means you just split into various types of surfing. Only
Actually, I didn't.
gaming or other things.
No, sir. I actually initially thought to do specific types of internet addiction, sir. For each type, there is different scales or
So
available.
you took it
for
in general.
1 month study, we just included generally, sir.
So it's a generalized
Yes, sir.
observation, 42%.
Yes, sir.
Okay. Since it's a new thing, we don't know which is correct or wrong. This may differ from area to area, availability of net bandwidth. Even we are now struggling with the bandwidth. So this is in the very, very early phase. It's a very westernized topic, and how we are going to adapt or how we are going to incorporate into our specialty is a $1 million question. Okay, thank you.
Thank you, sir.
Thank you, Dr. Vijayalakshmi. The next presenter is Dr. Amit. Dr. Amit Kumar.
Good afternoon, everyone. The topic of my study is Good afternoon, everyone. The title of my study is Prevalence of Depression, Anxiety and Stress Among Interns in a Medical College at Puducherry. About introduction, depression is among the most common psychiatric disorder encountered in day-to-day psychiatric practice and is characterized by low mood, changes in appetite and weight, changes in sleep and activity, lack of energy, feelings of guilt, problem thinking and making decisions, and recurring thoughts of death or suicide, which must last at least 2 weeks. Anxiety is an alerting signal and warns of impending danger, which prompts a person to take measures to deal with a threat. Stress can be described as a circumstance that disturbs or is likely to disturb the normal physiological or psychological functioning of person. These all definitions have been taken from Kaplan and Sadov's synopsis of psychiatry. Life in a medical school is pretty different than that in the high school. This study was undertaken with the hypothesis that the medical students and interns face a tougher life than the general population. They have to clear an entrance exam to get into the medical school, and they are vulnerable to many mental health disorders, including depression, anxiety, and stress. The many contributing factors for such mental ill health could be attributable to increased study demands, being away from home, language barrier, and poor academic performance. In past, several studies have been conducted on medical students, but there were few studies which were done on interns. And we believe that the life of interns are different than medical students because they have to do night shifts, they have to prepare for the entrance examination of postgraduate, and they have become a part of the medical treating team. In about certain references, there were certain similar studies conducted by Animesh Gupta, Leena Rahul, and others, in which prevalence of psychological stress and depression was found to be 83.7 and 72.9% respectively. Similarly, in a study conducted by Anshuman Sharma, Sanjay Kumar Gupta, and others, prevalence of depression among medical students was found to be 31%. Our study aims to find out the prevalence of depression, anxiety, and stress among medical interns. The research question for this study is, what is the prevalence of depression, anxiety, and stress among interns in medical college at Puducherry? The objectives were to estimate prevalence of depression, anxiety, and stress among interns, to find the association between various factors such as interpersonal problem, family problems, substance abuse, psychiatric and medical comorbidities to depression, anxiety, and stress among interns. It was a cross-sectional study which was conducted in Sri Venkateswara Medical College Hospital and Research Institute, Center, Puducherry, which is a tertiary care center imparting undergraduate and postgraduate medical education. The study period spanned from March 2022 to May 2022, and a convenient sampling method was adopted. We have calculated sample size using the formula and is equal to 4 PQ by D square, and the prevalence in the previous study, which was 31, has been taken as P. So our using OpenAPI version 3, the sample was calculated to be found to be 132. We had got the clearance from the ethics committee, wide number 06/SPNCH/IEC, or certificate number March 2022. The inclusion criteria in the study were all the interns who were willing to participate and who gave data, and exclusion criteria, those interns who were not willing to take part in the study, as well as those who were, okay. So the data was entered in SPSS version 23.0, and this is the result we got. Out of 135 interns which had responded, 3 forms were incomplete and we rejected. Total 132 samples we have taken. In that, married were 0.8% and 99.2% were unmarried. And I will come to the final this thing. Using G-square test and t-test, we found that there was significant relationship between depression, anxiety, and stress to various factors like interpersonal problem, family problem, and problem related to study. In this, we can see there is significant correlation where P is less than 0.5 in interpersonal problem, family problem, and problem related to study. So, the discussion, this study was conducted with the objective of assessing the prevalence of depression, anxiety, and stress among interns, with a hypothesis that they are more vulnerable to these mental ailments. Nearly half of interns had shown some level of depression and anxiety, and nearly 1/4 had stress. The findings are slightly different compared to some previous studies, in which prevalence of depression was nearly 31%, and in one study, however, it was significantly higher than our study. A strength and limitation of the study. We had a very good response rate. I had given personally the questionnaire to 136 interns, out of which 135 had responded. And we had a good response rate. And the limitations were, since the investigators and the participants were from the same institutes, so this it could have been a barrier, like giving a personal data information. And since it was conducted in a singular institute, the data cannot be generalized to the whole intern population. And we did not exclude the prior psychiatric illness, which could have been a confounding factor. So in conclusion, we find that the prevalence of depression was 49.3%, of anxiety 52.2%, and the stress 28.8%, which is significantly higher than the what we see in the general population, which is 1.9 to 3.2%. So at last, I would say that this study indicates that some we have to take certain steps to we have to interfere so that interns are better able to cope up with the stress. We can have some role play or video in which they can be taught how to deal with various challenges during internship and also further in life. So, and I would like to acknowledge my college for giving me permission to conduct a study on interns, and a special vote of thanks to all the interns.
One question.
Yes, sir.
Was it any specific year was selected for the survey?
Sir,
All students, all only interns.
all interns.
So then means there is 65 out of your 135 means 50% suffering from depression, means they need active management. How can they treat them? Others? That is alarming. Even anxiety is more than that. So there must be some technical error in assessing, because you gave a simple questionnaire.
Yes.
You didn't ask them, and you have to assess whether it is a real anxiety or depression. Sometimes questionnaires give wrong information, just like AI. So that may be the serious limitation of the study. Any question from the floor? You just reply to my question. Can it be a assessment bias?
Sir,
See, just giving a questionnaire and instead of having a didactic or personal interview.
Sir, I had given two questionnaires. One was related to socio-demographic data. Another was -21 scale, which was developed by Lovibond and Lovibond. This is the short version of -2042. So since I had a shorter period of time, the study period was conducted in 3 months duration, and -21 includes both all three: depression, anxiety, and the stress. So I thought it's a better tool than HAD and other
First,
things.
the scale should have been Indianized or has to be standardized to our standards, and it should be in a regional language. That would have given a better result. Okay, anybody from the floor? Okay, thank you for presentation.
Thank you, Dr. Amit. The next free paper candidate is Dr. Annie Beena Paul.
All presenters, please note, you'll get a beep at the 4th minute, which means you have 1 more minute to wind up. Please wind up by 5. There are a lot of you here. Otherwise, 1 or 2 of you will have to stop. 5, we close. So please cooperate so that the others get a chance, right? Then we'll have 2 minutes of discussion. Yeah. So you'll get 1 beep at before 1 minute. The last minute, you'll get a beep. So you know you've got to wind up within a minute. Please do that so that the others don't get stuck. Thank you.
My study is on postpartum depression in women availing maternal health services in tertiary care hospital. Postpartum depression has a significant impact on the health of both mother and child. Mothers who are depressed are considerably more likely to be disabled and to neglect their own needs, which may have a negative impact on the early development of infants and increased maternal mortality. Postpartum depression is influenced by multiple psychosocial factors, including past psychiatric illness, poor marital adjustment, socioeconomic level, child gender, and lack of social support. Need for study. Depression as a cause of maternal morbidity and mortality has been recognized and acknowledged in the West, and screening for the same is being recommended and implemented as a part of routine antenatal and postnatal care of women. Few studies have been done in the developing countries to assess the problem of postpartum depression. Objective: to study the prevalence of postpartum depression among women in tertiary care hospitals and to find the associated risk factors of postpartum depression. Methodology: it's a cross-sectional study. It's conducted in Government Keelpark Medical College, postnatal ward and OPD. The target population is mothers during the postnatal period. Sampling method is convenient sampling, and study period is 6 months. Inclusion criteria: women admitted or attending tertiary care hospital within 4 weeks of delivery and women aged above more than 18 years. The exclusion criteria is women with major medical illness and non-consenting and non-cooperating women. Materials and methods: Edinburgh Postnatal Depression Scale was used to screen for depression among study participants. Women who scored more than 13 were considered positive for postnatal depression. The socio-demographic data and other risk factors were assessed using semi-structured questionnaire. The data collected were entered in Excel and analyzed during SPSS 22. The categorical variables are given in proportions, and chi-square test was used to find the associated risk factors. The sample size of the study is 100. So this is the distribution of socio-demographic details. The mean age of the study participants was found to be 25.9. About 76 of them belong to the Hindu religion, and most of them were of higher secondary education or graduate. Most of them belong to the lower socioeconomic status, and most came from joint family. So this is the distribution of risk factors. So we have analyzed here the marital relation. Most of them had a good marital relation. Out of the 100, 18 had a past medical history, which included diabetes, hypertension, hypothyroidism, and epilepsy. 4 had a past history of suicide attempt. 12 of them had a family history of suicidal death. And about equal proportion of primary and multiparous women were included in the study. 8 of them had a bad obstructive history, such as history of stillbirth, abortion, or intrauterine death. 40 of them gave birth to female child, while 60 gave birth to male child. Then 72 were of normal vaginal delivery, and 28 of cesarean section, and 28 of them had children with neonatal problems, which included respiratory distress, jaundice, or seizure. So this, out of the 100, 12 of them were screened positive for postpartum depression, scoring more than 13 in Edinburgh Postnatal Depression Scale. So the prevalence was came out to be 12%. This is the comparison of postpartum depression with the socio-demographic factors. As we can see, the 22% of the population was Muslim population. Education, most of them had all the illiterate population had depression, while most of them were educated up to primary education. Most of them belong to the lower socioeconomic status, and about 13% were from the joint family. This is the comparison of postpartum depression with other risk factors. So the study participants with poor marital relationship were found to be a significant factor for postnatal depression. Past history of suicide attempt and past history of and family history of suicidal death was also found to be as a significant factor for postpartum depression. Discussion: the prevalence of postpartum depression in our study is found to be 12%. A study conducted in Oman using the Edinburgh Postnatal Depression Scale have shown results of prevalence of 13.5, which is similar to our study report. So poor marital relation, family history of suicidal death, and past history of suicide attempt among women were significant risk factors of postnatal depression in our study. In conclusion, the findings of this study should alert healthcare professionals that postpartum depression needs to be screened for in usual antenatal and postnatal care of women. It is essential that every country obtains local evidence concerning the problem and develops low-cost, non-stigmatizing, and accessible interventions to address it. Thank you.
Thank you. That's wonderful. You kept in time. Any questions from the audience? What was the correlation between joint family support and the prevalence of depression?
So the joint family, as a factor only, the support was not measured in this. Only how many of them belong to the joint family and how many of them belong to the nuclear family was seen, and most of them were from joint family. It was not a significant factor per se in depression. Sir.
So we don't think joint families system helps, protects the woman during.
In this study, it was not found to be a significant factor.
There's no
but-
significance, is
yes,
it?
sir.
Okay. Anyone else? Yeah. 1 second.
In your slide, it is put as significant number of cases postpartum depression in fair marital relationship.
Yes, sir.
But you said it's correlated with poor marital relationship.
Sir, actually, it
Go to that slide. Results. It was put as poor, fair, and
fair,
good.
yes, sir. Good, fair, and poor, sir.
But it is just against the fair relationship.
Good, fair, poor. Out of 4 people who had poor marital relationship, 4 of them had screen positive for depression, sir.
No. Should have been a little bit down. 0.001 in the p-value.
Yes, sir.
It's just against the fair marital relationship.
No, sir. Actually, marital relationship, sir. It is combined for all the things, sir.
Okay. Compare with the other relations.
Yes,
I mean,
sir.
good and poor.
Sir,
Fair.
the p-value is for the marital relation, sir.
Okay, it's okay.
Okay.
Anyone else? Thank you for your presentation. Thank you.
Thank you, Dr. Annie. The next presenter is Dr. Jayashri.
Good evening, everyone. Today, I want to present on a topic, Size Zero, a Social Paradigm. This is a case series which highlights the impact of society's influence on young adults' perception of their bodies. The advent of social networking sites have a wide range of developmental consequences, especially on adolescents and young adults. Social media can influence positive and negative behaviors on a background of peer influence. It is estimated that 1 billion people around the world have Instagram accounts. Most of them are under the age of 25. Instagram is becoming the most used social media by students, teenagers, and young adults. This case series discusses 3 college-going students who presented with features of body image disturbances ranging from eating disorder, binging, purging, to body dysmorphic disorder. The common feature among all of those students was their daily usage of Instagram and the society's influence on the perception of their body image. First case is of a 21 years old female medical student who was from an urban background. She presented with complaints of poor eating habits, excessive dieting and exercising, multiple acts of self-harm, purging behavior for a total duration of 5 years. She was overweight in her childhood and has been bullied for it. She started playing sports and exercising to get fit. She would also skip multiple meals and would engage in occasional binging followed by purging. Patient also had a prolonged use of Instagram and would often look at dieting regimes and fitness videos. She always felt she was overweight in comparison to them. She also had history of multiple acts of self-harm, which she described to have helped her escape the distress of not being perfect. However, the patient's BMI was normal, but she was engaging in a lot of purging activities also. And she also had the Russell sign on her knuckles on examination. She was diagnosed as atypical anorexia nervosa and was started on low-dose fluoxetine and cognitive behavioral therapy. She has been regular on treatment and is now improving. The second case is of a 22 years old male student from a semi-urban background who also presented with complaints of excessive concern about the size of his breasts. He explained that he has gynecomastia, about which he has seen on Instagram. He also had multiple surgical consultations and various radiological investigations to rule out gynecomastia. Patient was fixated on his perception of the body part and was requesting to have surgery. Despite repeated reassurance, his distress did not subside and he was referred to psychiatry from the surgery department. He was diagnosed as having body dysmorphic disorder based on the history and investigations, and he was started on CBT as per the NICE guidelines. Later, a low dose of fluoxetine was also added. This patient has also been on regular follow-up and is showing minimal improvement now. The last case is of a 21-year-old female student who presented to the OPD with complaints of being excessively concerned about the type of food she takes, exercising excessively, and also not being happy with her body shape. She has also been using Instagram regularly. She is also one of those influencers who uploads videos on a regular basis. Patient described that the society expects her to be a certain way and is feeling distress about not being able to fulfill their expectations. She has also not engaged in any set regimes or programs for weight loss, but most of the intense and erratic things she has tried is from social media. Patient was started on CBT and a low dose fluoxetine a year back, but she has not been on regular treatment. So discussion, the striking resemblance between the discussed cases is that the patient's perception of the body image was majorly influenced by the society in face of apps like Instagram. Instagram has become an app with most users within a few years. It is an app that mainly focuses on sharing photos, which is used by a majority of world's youngsters explicitly. This is surprising yet dangerous. 1 in 5 teens say that Instagram makes them feel worse about themselves. They struggle with mental health, say that Instagram is making it worse, and the social comparison is also worse on Instagram. As soon as Meta announced they plan to launch an Insta for children, a famous magazine called Wall Street Journal has made the following statement based on the surveys conducted. The perfect image, feeling attractive, and having enough money are most likely to have started on Instagram. Instagram focuses on the body, face, and lifestyle in comparison to other social media apps. People using this app tend to share only the highlighted versions of their lives to make viewers develop a sense to look perfect. A surge of hormones during adolescence which change their physique from that of a childlike appearance to a more adult-like shape. It is natural for teenagers to have concerns and be conscious about their bodies, to be experimental and curious. Diseases like anorexia nervosa or bulimia and other eating disorders, they were commonly found in Western countries, but now they are becoming increasingly common in India, and Instagram is an important reason for these diseases manifesting. This is appalling. A lot of young people are marching towards this state, and we will be witnessing these issues with a lot of students, female more than male, in the near future. Thank you.
My question here is whether this social paradigm size 0 is promoted or is due to the is a cause or effect of Instagram. Because to be frank, I don't know what is Instagram. I know it is a photo sharing app. That's only, because there are a lot of apps. I don't know how many people will be using, and how can we follow this Instagram to get a finding whether it can be generalized. You have to answer.
Yes, sir. The size 0 is a thing that was initially, it was made famous by the fashion magazines. But nowadays on Instagram, there are many influencers who are promoting fitness regimes and diet regimes who claim that if you follow this particular regime, you can attain the size 0. So most of the Instagram's users are young adults. That is what the surveys which have conducted, they have found. And also now Instagram is planning to launch an app exclusively for children. So we are expecting that from the young age, people are made to believe that this is how your body should look like. And that can be a cause for this disorders.
Just on the right side, I want to ask, how many of you are using Instagram here? Just raise your hands. Okay, almost 50%. Almost 50%. By head count. Yes. Okay. So Instagram plays a serious role in our psych, we have to decide.
Yeah, it's true that what you say is true. The younger generation is really addicted to Insta, and approval from the Insta community seems to play a significant role in the mental contentment and satisfaction that they get, rather than direct one-to-one validation that they get in real life.
Yes,
It's
sir.
the Insta validation that they want. It is a phenomenon that you're watching with sadness, because we know it's a virtual world, and but so much of importance is being attached to that validation and support from the at least acknowledgement from that group. True. I think this is an area of possible research, and more papers will be coming up, because this is something that's going to really catch on. Both the internet addiction and the impact of social media is going to have a significant role in the lives of youngsters, especially. The younger generation really is influenced by what they see and hear on all this social media and the net. Yeah. Thank you so much. Yeah.
Thank you, Dr. Jayashree. The next presenter is Dr. Sobia.
My topic for presentation is infertility and psychological trauma. Introduction. Infertility is often a silent struggle. It's a life crisis affecting patients all around the world. The patients who are struggling to conceive report feelings of depression, anxiety, sleep disorders, eating disorders, personality, and relationship and behavioral problems as well. The inability to reproduce naturally can cause feelings of shame, guilt, and low self-esteem. These feelings in turn leads to various degrees of psychiatric problems like depression, anxiety, and leading to poor quality of life. Patients who undergo ART are at a significant risk of experiencing psychiatric disorders, and it is important to recognize, acknowledge, and assist these patients as they cope with their infertility diagnosis and treatment. A recent literature review on the prevalence of psychological symptoms in infertility concluded that 25 to 60% of infertile individuals report psychiatric symptoms, and that their level of anxiety and depression are significantly higher. We had a patient aged 34-year-old married female who studied MCA, who's a housewife from semi-urban area, belonging to a middle socioeconomic class, Tamil-speaking Hindu nuclear family, was brought by the husband, and the history given was reliable, adequate, and consistent. She presented with the complaints of suspiciousness, hearing voices, feeling that someone is controlling her, decreased interaction, lethargy, lack of concentration, and loss of interest, and decreased sleep for the duration of 2 years. She had a history of past psychiatric consultation where she was taking medications but reported not much improvement of symptoms. She had a history of IVF treatment for these 2 years with hormonal injections alternating with GnRH agonist as well as antagonist, with failure of 2 cycles. No family history of psychiatric illness. On MSc, the patient was conscious oriented, moderately kempt with decreased psychomotor activity. Her speech sample, she was replying to the question relevantly and coherently with increased reaction time. Her thoughts showed referential ideas, persecutory ideas, and with depressive cognition. And her cognitive functions were normal, with insight being grade 2. All routine investigations were done and the reports were normal. Pharmacologically, we advised her to withhold her IVF treatment and to stop the hormonal treatment which she was taking. And we started her on prolactin sparing antipsychotic and benzodiazepine for her sleep. Gradually, we increased the dose, and now she is maintaining well with the medications. The social analysis for her indicated that it requires a holistic look, and we called for a family-based structural and behavioral modification approach. The intervention was done on the individual level as well as at the family level. Discussion. A considerable lot of previous studies showed the most commonly the infertile women presenting with the depression and anxiety. Here we had a patient who presented with the psychotic symptoms, who underwent IVF treatment with hormonal injections. Infertility as a central focus of identity, especially for women. The childless women experience stigma, isolations, and even in few places, violence in both physical and psychological forms were also reported. Patients who undergo ARTs are at a significant risk of experiencing psychiatric disorders. Hence, a holistic approach is essential while treating an infertile woman. The population of infertile women is increasing because of various causes like physical, psychological, endocrinal, social, etc. The psychological factors such as stress are not only the cause but also the consequence of infertility, leading to mental health issues. Various ARTs are now available, but there are many barriers to seek them, and the techniques are also contributing for mental health issues. Women undergoing assisted reproduction do appear to be at a greater risk of psychological distress, particularly if the treatment was unsuccessful. So, psychological and social needs should be adequately addressed. Hence, a comprehensive multidisciplinary approach is essential, and there is also a need for regulations and monitoring in this field. These are my references.
Thank you. Thank you. Any questions? As you mentioned, there are so many causes for infertility, medical and social, as you said. So is stress and associated depression or distress itself a cause of infertility? So they are sort of one.
There are few studies reporting this.
Yeah.
Even stress and depression are also a cause of infertility.
Right? So is that a cause or an effect? And the second thing is, you're talking again about social issues. You mentioned it 2 or 3 times. Now, this girl you said is somebody who has finished her MCA. There are many households where well-educated women prefer or are being made to stay as, be homemakers. And at one point, I think they get frustrated, and that could contribute to the psychiatric illness that they had pre-morbid, isn't it?
Yeah.
Even before the infertility treatment, you said she had some issues. So is that related to her not going to work and staying at home in spite of her educational qualification?
No, sir. For the same complaint, she was getting treatment from other psychiatrists, private psychiatrists, for which she didn't show any improvements.
But
because
that
she
was before she started or after she started the infertility treatment?
after she started, all the symptoms emerged once she started with the hormonal injections.
Okay. Anyone else would like to ask?
So I have come across a similar case where the patient went in for regression. A grown-up lady behaving like a 8-year-old girl, always vaping, just throwing temper tantrums, and the husband realized it. They went for IVF, twice failed, and I have to stop that. And the patient improved with antidepressants. Now they want once again to try for that, but one thing you have to think, you have take into consideration the age limit. If it crosses more than 30 or 35, we know that the risk of this chances of Down syndrome and other congenital anomalies. So we have to be very careful in advising them. We cannot judge because they will go for, even the VIPs have got children through IVF after the age of 40 or by natural deliveries. So we have to be very careful. This is a very sensitive area. But one thing is clear. Our drugs definitely lead to mood disturbances during pregnancy or in women. That is the hormones, particularly the hormones. Hormone replacement is a very double-edged weapon. We have to be very careful. It can produce good things, but the number of the incidence of this negative effects are more than the positive things, as far as I am concerned. So we have to be very choosy. The endocrinologist will not consider about the mood changes, or the physician. You have to be watchful. Anybody from the floor? Okay, thank you for your presentation.
Thank you, sir.
Thank you, Dr. Sobia. Kind request, we have another 15 more candidates who have to present in the next 1 hour. And following that, there's going to be the PG preliminary quiz in the same hall. So let's try to stick on to the time. We now call upon Dr. Shanti. You can present.
Good afternoon, one and all. I'm Dr. Shanti from Kilpack Medical College. My study topic is overlap of anxiety and depression in patients with migraine or tension type headache. The most significant psychiatric comorbidities that affect the prevalence, prognosis, therapy, and clinical outcomes of migraine and headache have been proven to be mood and anxiety disorders. According to studies, migraineurs are 2 to 10 times more likely to experience mood and anxiety disorders than the general population and are linked to a lower quality of life and a higher risk of suicide. The International Classification of Headache Disorders, according to the second edition published in 2004, confirmed this headache pattern as a new diagnostic secondary headache category called headache attributed to a psychiatric disorder. Justification: most workups for common headache complaints have negative findings, and such results may be frustrating for both the patient and physician. There are very limited number of studies reported on prevalence of psychiatric comorbidity in patients with headache from India till date. Knowledge of the psychiatric comorbidity in headache would add to the framework of the global campaign to reduce burden of headache worldwide. The objective: to estimate the prevalence of anxiety and depression in patients with migraine and tension type headache attending the tertiary care hospital. Study design is a cross-sectional study. It is done at Government Kilpack Medical College, Neurology OPD. The target population included patients with diagnosis of migraine or tension type headache as per the International Headache Society Guidelines ICHD-3, which was published in 2008. Sampling method: it's a convenient sampling. Study period was for 6 months. Inclusion criteria: patients aged above 18 years and participants who were able to give the consent. Exclusion criteria included patients who are under treatment for anxiety and depression, disturbance in cognition, vision, language, and hearing, history of substance use and withdrawal, intoxication, other secondary causes of headache like trauma, pheochromocytoma, cranial pain, sinusitis, epilepsy, possibly which are associated with headache, were excluded. My sample size was calculated and my total sample size included 100 patients. A semi-structured proforma for collecting the socio-demographic and clinical variables was done, and I assessed the depression and anxiety using the Hamilton Depression Rating Scale and Hamilton Anxiety Rating Scale. The headache pain intensity was assessed using an 11-point verbal rating scale. Data was entered in MS Excel. Statistical analysis was done using the SPSS software version. Numerical data like age was summarized with mean and standard deviation. The categorical data like gender, education, occupation, socioeconomic status was summarized as proportion, and they were given as percentages. The t-test was used to compare the continuous variable, while the chi-square test was used to compare the categorical variable. Demographic details: our population included majority were the female patients, about 62%, and most of them were married, belonging to the lower socioeconomic status, and most of them have completed their higher or higher secondary level education. The intensity of headache, which was assessed using the 11-point verbal rating scale, which was actually rated from 0, indicating no pain, and 10 is the worst pain. Mild is between 1 to 3, moderate is 4 to 6, and severe 7 to 10. The patient will actually score these ratings. According to that, 13% they were showing mild, the intensity of headache was mild, and for 54%, the intensity was moderate, and 33%, the intensity was severe. Then for the 100 patients, Hamilton A and Hamilton D rating scales were done, and the prevalence of depression and anxiety was around 26% and 19% among the patients who were presenting with migraine or tension type headache. Out of the 26, 10 were having grouped under 10 were mild depression, and 10 under moderate depression, and 6 under severe depression. Similarly, for anxiety, out of the 19%, 9 were grouped under mild, and 7 under moderate, and 3 under severe. And certain factors were also taken into account, like aura and precipitating factors. Aura was present in 38 patients out of the 100, and precipitating factors were present in 41%. And duration of headache was also taken into account. Association of study variables with depression and anxiety: it was found that there was significant p-value found in with the marital status as well as the patients presenting with depression and anxiety. Out of the marital status, most of the divorced person showed a significant p-value. Similarly, there was a significant p-value and the association of aura and precipitating factors with patients presenting with depression and anxiety. The headache intensity was also significantly associated with depression and anxiety, and out of which severe patients presenting with severe intensity of headache were more significantly associated. The prevalence of depression and anxiety in our study is 26% and 19%. The depression and anxiety is significantly higher in patients who were divorced, widowed, and compared to married. A study by Wei et al. Had shown the prevalence of depression and anxiety to be 15.2 and 10.9%, which is much lower than my study. This difference can be attributed to difference in ethnicity and sample size, but similar to ours, this study also showed increased prevalence of depression and anxiety in divorced when compared to married. The aura was present in 38% and precipitating factors in 41%. Both aura and precipitating factors have significantly positive association with depression and anxiety. Similarly, there was higher prevalence of depression and anxiety among patients with increased severity of headache in our study. Conclusion, patients with headache or migraine had shown a significant association with depression or anxiety in our study. To implement successful treatments and enhance the headache care, clinicians need to understand the pathophysiology of headache and its consequences on depression and anxiety. Our study emphasizes the need for screening of depression and anxiety among patients attending the tertiary care for headache and migraine. Thank you.
Thank you. Just one thing. One thing is puzzling. In the 6 months period, you had 100 cases. And you had it from the neurology department or?
So neurology OP, sir, will be posted every 2 days a week.
So our assessment and their assessment may be different because migraine is a very short-lived thing. So it may be there for 1 or 2 days. So how can we say a patient is having depression following migraine? Because once the condition is migraine, the headache is terminated or controlled, patient will be normal. So he or she is having depressive symptoms, we have to quantify or we have to justify. Anxiety may be there. As you said, there may be appearance of the future attacks because they would have a severe vomiting, which unpleasant things. So this depression, we have to justify. What do international studies say?
So international study, they have a classified migraine as a duration of headache between 4 to 72 hours, which incapacitate them from doing their physical activities. And also it is present most of the day, sir, associated with the aura. Whenever it's present with the aura, it is debilitating to the patient to do their physical activities, routine activities.
Just I want to ask the incidence of depression and anxiety in Western people following this tension type of headache or migraine headache.
So it was similar. So one study it showed it was 21% of depression and 13% of anxiety, sir.
And one thing we must also know that the depression may also present with the somatic symptom as a headache. That also has to be taken into account.
Yes, sir. Other study has also showed the vice versa.
Yes. Any questions from the floor?
When aura is noted or when migraine is diagnosed, you're talking about the neurology department.
Yes, sir.
How well do they liaise with the psychiatric department?
So actually, weekly twice we go there, so we are able to follow up the headache patients.
No, you go and do the follow-up, but do they refer to the psychiatrist? Do they include a psychiatrist in their
No, sir.
team?
No, sir, they don't.
Now, that's something we have noticed in many places.
They don't.
We know things like tension, headache, and migraine has a psychological background or influence.
Yes, sir.
But in many of these big centers, we don't find a psychiatrist as a part of the team that's handling this.
Yes.
It's all medicine. The newer the medicine, more expensive, of course. So those are prescribed left, right, and center. But there's no counseling or no involvement of a psychologist or a psychiatrist. Our help is not sought.
Sure, sir.
That's a sad state of affairs, isn't it?
Yes, sir.
So I do not know. Maybe you could influence twice a week. You go.
Yes.
Influence them to include a psychiatrist in the team that handles this sort of headache issues.
Yes, sir.
Yeah?
Yes.
Thank you.
Thank you, sir.
Thank you, Doctor. We now call upon the next presenter, Dr. Iniga Marie Divya.
Good afternoon, sirs. A very pleasant afternoon to one all gathered here. The topic I chose was religious faith, a protective factor against alcohol abuse. Now, introduction. The increased fascination stems primarily from whether spiritual and religious practices, commonly associated with personal transformation, may also help in transformation of substance use behaviors. Our objectives were to observe the level of religious faith among patients consuming alcohol, to find the association between the level of religious faith and pattern of alcohol use, and to explore the religious factors promoting abstinence. It was a cross-sectional study involving 90 individuals, and convenient sampling was used to recruit. Inclusion criteria involves male patients who were 18 years or older, who are clinically stable and who consented to the study. Exclusion criteria were female and other genders, patients who currently had withdrawal symptoms or had any other active symptomatic psychiatric illness, or who were in intoxication state, or who consumed any other psychoactive substance except nicotine. Audit scale was used to find the pattern of alcohol use, and Santa Clara Strength of Religious Faith questionnaire, which had a high internal reliability and has been used across various religions and nationality, was used to find the level of religious faith. 90 of these patients were recruited, interviewed, data was processed, and statistical analysis done. Now, coming to the results, all recruited patients were of mean age 35 plus, and most of them received education lesser than 10 standard, and majority of these patients were employed. Majority of them belonged to low socioeconomic status, and most of them were single, separated, or divorced. And only a few of them came from urban areas, and owing to the locality, majority were Hindus as well. This is a socio-demographic distribution. Now, average years of alcohol use was approximately 9 years, and 70% of them consumed alcohol in dependence pattern. And risk pattern was, the high risk pattern was seen in 23.3% of them, and severe risk pattern in 44.4% of them. 75.6% of them had high religious faith. And we took into consideration some religious factors, and about 14.4% of them consumed alcohol when on a pilgrimage, whereas 78.9% of them consumed alcohol while celebrating a religious festival or attending a religious event. When it comes to fasting, about 68% of them involved themselves in fasting, and out of them, 89% of them stopped alcohol during this period. And about 78% of them were previously taking alcohol in dependence pattern. Out of those who fasted, 87.3% of them abstained out of fear that they'll be punished by a higher power, and the remaining because they felt guilty or because others expected them to. Majority of these patients reported to have lower craving and higher motivation to stop alcohol during this period. 61.8% of them restarted drinking the same day the fasting was over, and only about 3.6% of them still remained abstinent after 1 month. There was no significant correlation between the level of religious faith and pattern of alcohol use. Now, when it comes to nicotine, out of 55 patients who indulged in fasting, about 78% of them consumed nicotine in some form. And out of them, only 20.9% of them abstained from nicotine during the period of fasting. Now, coming to discussion, some studies show that religious faith and pattern of alcohol use were inversely proportional to each other. Our study did not yield such results supporting these studies. This might have been because we did not involve patients less than 18 years, or because only a minority of them were under 25 years. Religious cultural practices as a part of religious faith of acceptable drinking could have contributed to this. Though no religion directly promotes drinking, some religions are generally considered to have strong prescriptive norms against the use of alcohol. According to our study, no specific religion yielded significant protection against an individual consuming alcohol in dependence pattern. Just as we anticipated, only about 14.4% of them consumed alcohol when on a pilgrimage, and a majority of the participants stayed abstinent from alcohol while fasting for religious reasons. Though 78% of them usually consumed alcohol in dependence pattern, almost all of them reported having lower craving and increased motivation to stop alcohol during this period. Fear of being punished by a higher power seemed to be the major reason as to them stopping. This abstinence, however, seemed to have short-lived, as majority of these patients restarted drinking the same day the Viradam was over. Though religion promoted abstinence during fasting and pilgrimage, the same did not apply during religious festivals. This might be because it was culturally accepted and the former was usually frowned upon. In contrast to 88.7% of the individuals abstaining from alcohol during fasting, only about 20.9% of them abstained from nicotine during this period. Interesting finding was that 3 individuals who were priests consumed alcohol in dependence pattern with the alcohol they received as offerings. Now, coming to conclusion, though according to our study results, religious faith did not seem to directly protect an individual from consuming alcohol in dependence pattern, it is found to act as a strong factor in promoting abstinence and encouraging active participation in religious practices like Viradam and pilgrimage, or incorporating such practices as a part of therapy might help ease the route to recovery from alcohol abuse. These are my references. Thank you.
Thank you.
Thank you, sir.
Just what you say, by maintaining the religious faith or maintaining religious activities, you can prolong abstinence. Is it your inference?
No, sir. In the beginning, early stage, when they're struggling with abstaining from alcohol, it can be used as one of the factors which motivates them to maintain the abstinence. At least we have some 40 days during which we can initiate other
Yes.
therapies. So it's easy for them to recover.
Usually I used to tell, whenever the individual goes for religious fasting and completes it, the next day you should have another fasting, I will say, for another temple, so that you can maintain. It's not possible. They will be the core alcohol users. Once they complete the religious fasting, they will involve in binge. That leads to a lot of problem. So whether it's a controlled drinking or a phase-wise drinking, it's a very difficult thing. But strong believers in faith, religious faith, will not go for alcohol usually. So it's they accept because of the family compulsion. Half-heartedly they try that. Any questions from the floor? And one more question before conclusion: is the religion you just generalized, or you split it per individual religion, just like Hindu or Muslim or Christian or Jain or Sikh?
Yes,
Did you study?
we took into consideration all the religions, sir, and the question we used is a question which can be generally used across all the religions.
Because certain religion, it is considered as a sin. Alcohol and smoking and involving in this substance dependence is considered as a sin,
Yes,
according to religious faith. But they are also using.
yes, we were
That's
not
the
able to
thing.
find any strong correlation.
Correlation. Yes.
Yes.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Renika. The next presenter, Dr. Gokul.
Good afternoon, all. My presentation topic is prevalence of generalized anxiety disorder among patient attending medicine outpatient department in a tertiary care center. It's a cross-sectional study. In introduction, generalized anxiety disorder is characterized by a persistent and overpowering anxiety with symptoms such as fatigue, restlessness, and difficulty concentrating, as well as somatic signs that include heart palpitation and respiratory distress, which is severely affecting the patient's quality of life. The prevalence of generalized anxiety disorder is found to be high among patients attending medicine outpatient department and associated with greater morbidity. The present study aimed to determine the prevalence of generalized anxiety disorder among patients presenting to the medicine outpatient department. The primary objective of the study is to detect the prevalence of generalized anxiety disorder among patients presenting to medicine outpatient department in a tertiary care center. Secondary objective is to determine the association between prevalence of generalized anxiety disorder and medical diagnosis in patient attending medicine outpatient department. It's a cross-sectional observational study conducted in a patient attending medicine outpatient department in a tertiary care teaching hospital. The participants of both gender between the age group of 18 to 65 were included. The semi-structured interview was used to collect the socio-demographic data. Generalized anxiety disorders, GAD-7, was used to screen the patient for anxiety disorder. And those who screened positive with a score of 10 or more underwent a detailed evaluation with structured clinical interview for DSM-4 axis 1 disorder. Results: a total of 127 participants with a mean age of 41.33 years were recruited. In that, 52 were males and 72 were females. Common medical diagnosis among the participants were diabetes mellitus, systemic hypertension, and hypothyroidism. Among the study participants, 22 were screened positive for GAD-7, and on detailed evaluation using SCID-1, participants were found to have around 13 participants were found to have generalized anxiety disorder. Discussion: a review of anxiety disorder in India done by Trivedi et al. Found that prevalence of GAD was 5.8%. And a systematic review on prevalence of anxiety disorder done globally found that GAD had the highest lifetime prevalence of 6.2%. And a study by Quinn et al. Conducted in internal medicine outpatient department in China revealed that prevalence of all types of anxiety disorder was 31.91%, and in that GAD was 8.03%.
And another similar study done in cardiology outpatient department found that 49% of the subject had anxiety disorder with varying severity. The strength of our study is use of standardized instrument conducted in a naturalistic setting and use of SCID to confirm the diagnosis after screening. Limitation of the study, it's a cross-sectional study design conducted in a single center. It's conducted in a tertiary care setting so that generalizability to other settings is difficult. Future direction, role of generalized anxiety disorder in the treatment adherence and outcome of medical disorders, and intervention studies to evaluate the treatment option in patient with generalized anxiety disorder in medicine outpatient department. Conclusion, about 1/10 of patients presenting to the medicine outpatient department were found to have generalized anxiety disorder. Routine screening using simple user-friendly tools can be considered in these patients in tertiary care settings for identification of generalized anxiety disorder and initiation of treatment. References.
Thank you. We have finished in time. One thing I want to tell is, in 93, when I was the postgraduate student, final year, I took GAD as my dissertation. So there were a lot of criticism. We had DSM-4 and ICD-9, yes. And both did not differentiate much among the anxiety. So they said it is a very vague topic. You cannot diagnose GAD in the clinical setting at all. Either it may be having a comorbid or it may be a symptom in some other major psychiatric illness. So now you said you used a scale for GAD. I think the status is same even after this 30 years or 29 years. Ever since my dissertation, I think the condition is same. I have never diagnosed GAD till date because it is very difficult to diagnose. Very difficult. If you probe, if you go by questionnaire, it can be easy. Otherwise, you can satisfy yourself that you have diagnosed GAD, but it's not GAD. It may be some other thing may be there. What is your opinion regarding this GAD? What do you take? What are the questions in the GAD scale, 7-item scale? You said.
It starts with whether you are feeling nervous and then feeling edge. So some of
was there any justification whether you are feeling nervous because you are seeing a psychiatrist, or is there any?
It's like for past 2 weeks with these
symptoms,
duration of for past 2 weeks. So whether they were screened positive with score of 10 or more, we'll go for structured clinical interview with use of SCID.
And you won't have any references. Very few or negligible number of reference can be seen in international literature regarding GAD, because most of the psychiatrists will not accept that there is a separate entity called GAD. It is an ICD. I think it is 42.02 or something. ICD-9. I followed that. Any questions from the floor?
Thank you, Doctor. Thank you for your presentation.
Thank you, Dr. Gokul. The next presenter, Dr. Mohan Prem Kumar.
Good afternoon. My topic is medication non-adherence among patient attending psychiatric outpatient department in a tertiary care hospital. I am Dr. Mohan Prem Kumar, and my guides were Dr. Partha Sarathi and Dr. Pradeep Tilagan, the Department of Psychiatry, Pondicherry Institute of Medical Science. Introduction. Nearly 30% of the global burden of diseases is attributed to major psychiatric disorders. The WHO defines adherence as the extent to which the person's behavior, including medication taking, corresponds with agreed recommendations from a healthcare provider. Medication non-adherence is a major hindrance to effective management of major psychiatric disorders. Objectives. Our objectives were to determine the prevalence of medication non-adherence among patients attending the psychiatric outpatient department in a tertiary care hospital, and to determine the factors associated with medication non-adherence among patients attending our OPD. Methodology. It was a cross-sectional study conducted in an outpatient setting in a tertiary care hospital. Participants of both genders above 18 years of age and who have been diagnosed with psychotic, depressive, bipolar and anxiety disorders according to ICD-10 were included. And for And patients should be on at least 3 months of medication duration to be included in the study. And patients who had an organic cause for the illness, and patients on depot injections, and patients presenting with acute exacerbation were excluded from the study. Methodology: the medication non-adherence was assessed using a 10-item medication adherence rating scale. A score of 5 and below was considered to be non-adherent. Results: our study included 184 participants, of which 100 were males and 84 were females, and mean age of the participants were 37.4 years. And as a result of our study, we found 29 participants were found to be non-adherent. This table shows the different diagnostic groups of the study participants, of which psychotic disorders of 83 in numbers, and bipolar affective disorder patients of 33, and depressive disorder in 30, and anxiety disorders of 38. Results: among the variables, age and socioeconomic status were significantly associated as a factor for medication non-adherence, and other variables such as duration on medications, number of pills per day, frequency of pills per day, occupation, and gender did not show significant association as a factor for medication non-adherence. Discussion: J.M. Luca et al. Conducted a study at a tertiary care hospital in Mysore, India, using medication adherence rating scale, and reported that 43% of psychiatric outpatients were non-adherent. And similarly, Taj et al. Conducted a study at a tertiary care hospital in Pakistan, and among different psychiatric illnesses, patients with a psychotic disorder were more non-adherent compared with depressive and bipolar disorder. In our study, we did not find any significant difference between the different disorder groups. In contrast to our study, Ibrahim et al. Conducted a study in a tertiary care hospital among psychiatric patients and found that dosing frequency was a strong predictor of medication non-adherence. And the strengths of our study: use of standardized instrument for assessing medication adherence, and representation of various diagnostic groups in a naturalistic setting. And the limitations were the cross-sectional study design and the self-rated design of the study instrument. Future directions: a longitudinal follow-up study would provide a better perspective on medication non-adherence among patients and various factors which influence it. Use of multiple methods to assess medication non-adherence will provide in-depth information. Conclusion: about 15% of patients with psychiatric disorders are non-adherent to medications. Age and socioeconomic status were associated with medication non-adherence. Assessment of various factors influencing it and methods to tackle it are necessary to address this important problem. These are my references. And, thank you.
Thank you for keeping in before time. And your conclusion, third part, what are the factors? Have you studied? Just you conveniently kept it by the side. What are the factors of non-adherence? Was there any attempt made in the study? You just studied about the number of non-adherent individuals.
Yes, sir.
Was there any reason or factors for that?
We generally use this questionnaire, and using this questionnaire, we rated the medication non-adherence, and using the social demographic profile, in the social demographic proforma, we included the duration of medication and what daily pill count.
You said one study showed, Ibrahim, the frequent use leads to a negative outcome.
Yes, sir.
Any other thing? Availability or
cost of medication.
Cost of medication.
That was also we included. But
not believing illness, family members, a lot of things are there.
Yes, sir.
It's a very short study, observational study. Okay. Anybody from the floor contribute or correct it? Yes.
Thank you.
My query is about in your exclusion criteria, you mentioned about 3 months who did acute exacerbation of symptoms were excluded in the study. So that acute exacerbation might be a cause of non-adherence to medication also. So if at all, if you do it in future study, so that acute exacerbation of symptoms can be included.
Yeah, we thought of it, but the reason for not including is that it is a self-rated questionnaire. So under acute exacerbation, the patient cannot be expected to fill that questionnaire. So only we have excluded that patient.
Okay, once the acute exacerbation settles, you can just include about the non-adherence. So that that exclusion criteria can be adjusted in future studies. Thank you.
Any predictors that you could think of for non-adherence?
Past history of multiple relapses due to non-adherence is a predictor, and poor insight about illness can be a predictor for non-adherence.
the role of caregivers in this?
Yes.
So, psychoeducation for the caregivers, if the time is taken by the psychiatrist to educate the caregivers about the importance and the, in the regularity has to be maintained and all that. If you are able to educate them well, I think the percentage of adherence will increase.
Yes, sir.
Good. Thank you very much.
Thank you.
Thank you, Dr. Mohan. The next presenter is Dr. Lasbondhar.
Good afternoon to one and all. Today, my presentation is on study on socio-demographic and clinical profile of patients with mental illness who were certified with disability certificate at a tertiary center. To introduce, disability means any long-term physical, mental, intellectual, or sensory impairment which in interaction with barriers, it hinders a person's full and effective participation in society equally with others. In India, 2.21% of the population have disability, and among this, 3 to 6% is due to mental disability as a result of having either mental illness or intellectual developmental disorder. And disability associated with mental illness, it is a major contributor to the global burden of disease. And the disability certification in psychiatry, it remains underexplored due to issues of confidentiality, stigma, lack of awareness among the public as well as the mental health professionals. So my study evaluates the socio-demographic and clinical profile of patients with mental illness who were issued disability certificates over a period of 6 months, that is from November 2021 to April 2022. Various welfare schemes for people with disabilities from Government of India are as follows. Disability pension or unemployment pension, disability person scholarship, insurance scheme for the mentally challenged, income tax benefits, aids and appliances for multiple disabilities, family pension. That is, this will be given to the disabled after the death of their parents. Employment reservation, that is 3 to 5% of jobs in government are reserved for the disabled. Concessional bus passes and railway concession. Aims and objectives, it is to assess the socio-demographic and clinical profile of patients with mental illness who were issued disability certificates, and to assess the severity of disability in the mentally ill who were certified with disability certificates, to compare the disability among various disorders, and to assess the trends of utilization of disability benefits from the date of issue of these certificates. Coming to the methodology, study center was in Chengalpet Medical College and Hospital Department of Psychiatry. Period of study was from November 2021 to April 2022. It was a 6 months duration of study. It was an observational study, cross-sectional design. Sample size was of 100. And study population, consecutive patients attending Chengalpet Government Hospital who fulfill the inclusion and exclusion criteria. Evaluation of these subjects were carried out in the presence of a primary caregiver after obtaining the informed consent, and socio-demographic and clinical details of patients having the disability certificate were collected using semi-structured performer, and diagnosis was established using the ICD-10 criteria, and subsequently the current disability was assessed using IDEA scale, that is Indian Disability Evaluation Assessment Scale. Statistical analysis. The data were analyzed using a statistical package for social science software. Descriptive statistics, frequency and percentage were used. And p-value analysis were used to assess any significant difference between the age and level, between the groups, and level of statistical significance was kept at p less than 0.05 for all the tests. Coming to results, the results of this study showed that there is a significant association between the duration of diagnosis of illness and disability card certification, which has a p-value of 0.001, and between the socio-demographic profile and severity of disability as per the IDEA scale in 3 domains, that is in employment status in males, and primary earning members, again in males, that is being financially dependent, and duration of illness in females. And out of this, majority of them were found to be in the age group of 41 to 50 years, and most of them were male, coming to from rural background, Hindu by religion, getting a secondary level of education, were employed, most of them were married, and most of them belong to lower socio-economic status and belongs to nuclear family, and most of them were dependent on their other family members apart from their parents, and there was no history of psychiatric illness. And this is again the tables which I've explained, that there's association between duration of illness and the certification. And out of the 100 subjects, 82 of them were schizophrenia. And among the severity of illness, based on the IDS score, most of them were having moderate severity. And coming to the distribution by taluks, most of them was obviously from Chengalpet. And in the disability card details, more than 20 years, 45 of them got the certificates only after 20 years, and 22 of them didn't have any validity in the certificates, and 77 of them didn't get any benefits, and the reason of them, almost all of them didn't know what was the reason for the delay. Coming to the discussion, majority of the study were male. In that, it again was similar to the study which was done by Balhara et al. And again, there was a significant association between employment status and primary earning members, which was again similar in a study by Bahar et al. And there is a relatively long gap between the duration of diagnosis of the illness and disability certification. And again, this would mean a delay in disability benefits, and surprisingly, none of the study population knew the reason what was the delay of these benefits. And the period of, again, validity of the certificate was not mentioned in 22% of certificate. However, this needs to be mentioned clearly in the certificate in order to overcome the disabling barriers. And 90% of the subject was not satisfied about the disability benefits, and they wanted it more as it was the only source of income for many of them. And to conclude, our study concludes that there is a long gap which is more than 20 years between the duration of diagnosis of illness and the disability certification, and official information related to disability and various schemes by the government of India. It needs to be provided at grassroots level so that maximum number of beneficiaries can avail monetary benefits along with the other benefits at the earliest. And also the officials who are issuing the disability benefits, they need to be sensitized about the disability certification process, so that most of them, as most of them did not receive any benefits even after they were certified, and proper awareness and education is needed in order to help reduce the stigma, disability, and also in order to for a better utilization of these benefits. And this data might help in improving awareness about facilities and pathways available to assess in providing support to people with disabilities. These are my references. Thank you.
Most like a social study with the current practical problems faced by the individuals getting the certificate. But it is not in our hands. We can certify, but the sanctioning of the benefits is not within our purview. It's beyond our category, beyond our control. That one should realize. And even sometimes beyond the control of the sanctioning authority, that has to come from the high command. We have come across this for the past 20 or 25 years, wherever we go. Even after 4 years, when MLA came and told me, you give a certificate that I will make arrangement. He just insisted me and got the certificate for a chronic mentally ill individual. And after 4 years, I saw the patient. She simply said, "Enna sir, avar vandu kettaru avladha." After 4 years, see, MLA came. So it's a very difficult thing. Okay, anybody, any questions from the floor?
Continuing with what Dr. Kumanan said, it is also possible that the MLA was enjoying the benefits for all you know.
Maybe.
Because the patient has not got the benefits still, but he might be using it. There's another one part of the slide where you said the reason for the delay is not known. Meaning not known to the patient or not known to us?
Not known to the patient and both to us also.
Okay.
Like why they had not got
Why they have not
good proper time.
approached for the...
It's not known.
Anybody else? Thank you, doctor.
Thank you, Dr. Lasbon. The next presenter is Dr. Elilan.
Good afternoon, one and all. My topic was to assess the prevalence and socio-demographic factors associated with substance use disorders in adolescents, attending the tertiary care hospital, a cross-sectional observational study. So, introduction, the epidemics of substance use abuse in young generation has assumed an alarming dimension in India. The onset of substance abuse often stems in adolescence only. It is often linked to socio-demographic variables such as gender, age, family structure. So drug use interferes with children's normal development and increases the risk of experiencing physical, emotional, and mental issues. So multifactorial and interactive causal approaches are considered as an etiology of drug abuse. As a result of this analysis, a complex of risk variables, protective factors, that is respectively increases or decreases the chance of drug abuse in adolescents are identified. So the aim and objectives are to assess the prevalence and socio-demographic factors associated with substance use disorders in adolescents attending a tertiary care hospital. Materials, study was done in our Department of Psychiatry, GMKMC Salem. Duration was 3 months and sample size was 60 members, 60 adolescents. Study design is a cross-sectional observational study. Sampling was a non-random, convenient sampling was taken. Results were obtained and was from the uploading analyzing in SPSS software version 2. Coming to inclusion criteria, any adolescent person with age less than 18 years fulfilling for substance abuse or dependence were taken. Parents willing to give a consent or were taken. Exclusion criteria, under 18 adolescents report alone without parents are excluded. Adolescents with other major psychotic disorders were also excluded from the study. Tools, semi-structured proforma was taken, and BSTAD. It's nothing but a brief screening instrument for tobacco, alcohol, and drug use. It screens the single and frequency use quotient for the past 1 year of the 3 following substances used by the adolescents, that is alcohol, tobacco, and other drugs. Response categorized into 3 risk levels, that is no reproductive risk, lower risk, and higher risk. It was developed in 2014. It's a recent one. The other study was, the other scale was CRAFT, CRAFT. It's nothing but a car, relax, alone, forget, and trouble questionnaire. Stands for the keywords of 6 items in the second section of the assessment. Screens for the frequency of substance use in the past 1 year. Version was 2.1. Then POSIT, POSIT scale. It's nothing but a problem-oriented screening instrument for teenagers, which is a 139 questionnaire scale to identify the problems in 10 domains such as substance use, mental health, family relationship, peer relation, social relation, aggressive behavior. Then the next tool was MiniKit, neuropsychiatric interview for children and adolescent. Socio-demographic data, we can see that older adolescents, that is 6 to 18, were more, that is of 35 adolescents. No female was taken into study. Education, most of them were 12th, were 6th grade, 6th to 12th grade. Domicile was more than urban population, and the social status was lower, was the more contributing to substance use disorders. So in this chart, you can see the age of adolescents with substance use, which older adolescents are more than 60%. Education was about 12th grade was 28 adolescents, and was rural, urban areas was more prevalent than the rural was more prevalent than urban. Type of family, the nuclear family is more prevalent. Coming to family history of substance use, family substance use was about 20%, whereas substance use disorder was about 40%, which is more. Coming to the type of substance abuse by the adolescents was more common about alcohol, whereas it is followed by marijuana, and it is followed by other tobacco, alcohol. Coming to the factors associated with substance use are risk factors. Lack of supervision was the most high, whereas stress level was low. Whereas we can see the protective factors were low among all the 60 patients. The prevalence was about 1.2%, and the BTSD response was more of 34 adolescents were about tobacco. POSIT scale interpretation shows that the mean score of 11.5 for the substance use, mental health, and 9.5 for family relationship, and social was 7.2, least among for aggressive behavior. So discussion, the main objective study is to assess the prevalence and the prevalence was 1.2 percentage, and there are no single cases, and 67 belongs to rural population. Most of them were lower and lower class population, and 20 others were had family history of psychiatric illness. Depression, suicide, and generalized anxiety and acute psychosis are the most common psychiatric illness present in our group. The most common substance used by the adolescents are alcohol, followed by cannabis, followed by tobacco, followed by inhalants, which is less than 3. And the BTST showed a response of 19% for tobacco, for alcohol. The Portsit scale shows a mean of 11.5, and the aggressive behavior was very common among adolescents. So the urgent interventions like prevention of substance availability, strict locks, family involvement, and children of a broken family or a problem will be kept in a separate home. So de-addiction centers to be initiated and maintained separately.
Anyone would like to ask questions? Any doubts? Yeah?
Okay, what was your final conclusion? Sorry, adolescents?
So the lack of supervision and peer influence and easy availability are the most risk factors for substance use disorder.
Substance use.
Yes, sir.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Leighton. An announcement, anybody presenting posters, you can proceed to the next hall because it's happening right now. It's 4 to 5. Any poster presentation candidates here? Okay, thank you. So the next presenter is Dr. Nivedita.
Good afternoon. My topic is duration of untreated psychosis among patients with schizophrenia, a change over time study. Now, the duration of untreated psychosis refers to the time elapsing between the onset of psychosis and the treatment initiation. Now, schizophrenia remains untreated for a long time before being recognized and treated, and it frequently shows a chronic disabling course which dramatically impacts the relational and functional aspects of life. Now, reducing this delay in initial detection and treatment might improve the long-term outcome of the patient. It also helps to identify various psychosocial variables that can have an impact on the prognosis of the patient. Now, aims and objectives of the study is to estimate the duration of untreated psychosis and its variation over the years, and to determine the possible correlation between the duration of untreated psychosis and other independent variables like socio-demographic factors, family history, substance abuse like alcohol and cannabis, predominant presenting symptom, presence of aggression, and mode of onset. Now, the methods used in the study is a retrospective case record study, and the data is collected from the medical records department of tertiary care psychiatric hospital. It is a convenient sampling was done, and 30 samples was collected from each year from 1990, 1995, 2000, 2005, 2010, 15, 16, and 20, and the data was collected in a data collection sheet. Now, statistical analysis, the samples were divided into two groups, that is before the year of 2000 and after the year of 2000. Descriptive analysis was done comparing samples before 2000 and after 2000, and independent t-test was done to compare the variables between both the groups. Now, coming to the age, before 2000 and as well as after 2000, the most common age at presentation was 21 to 30 years. Coming to gender, the most common presentation was male gender. Coming to the economic status, the most common was lower economic status, which presented both before 2000 and after 2000. And alcohol use, 12% of alcohol use was found before 2000 and 16.3% after 2000. Coming to cannabis use, 4.4% of cannabis use was found before 2000 and 3.8% after 2000. Family history of mental illness, 80.2% had no history of any family illness, whereas in after 2000, 59.4% had family history of mental illness. Now, the presenting symptom, the most common presenting symptom was positive symptoms in both the groups. Coming to aggression, 50% presented with aggression in both the groups. And the mode of onset, the most common mode of onset was insidious, followed by acute and then subacute. Now, independent t-test was done in which So this is the variation of duration of untreated psychosis over the years. Now there is increasing trend of duration of untreated psychosis according to my study from 1990 to 2020, and significant difference is present for gender presenting symptoms, that is aggression, and also duration of untreated psychosis, which was identified by the independent t-test, and there is no significant difference for family history and any other substance use. Now, discussion, the trend of increasing DUP over the years may signify less awareness about mental illness in the community, and also stigma surrounding the mental illness is an important contributing factor. Now, lack of trained mental professionals and community health services can lead to longer duration of untreated psychosis. Rigorous strengthening of mental health services across the community should be done, and breaking the stigma surrounding the mental illness by educating others is important. Supporting people with mental illness by providing jobs and livelihood could change the outlook of people towards the mental illness and reduce the stigma. Now, limitations of the study, it's a small sample size, can limit the generalizability of the study, and it was done in a tertiary care in a short duration. Convenient sampling was done, and it's a retrospective case record study, so some data might be missing. These are my references. Thank you.
Thank you, Dr. Nivedita. It is somewhat interesting study finding out the duration of untreated psychosis, but I am not make me clear whether the duration of untreated psychosis is going on increasing or it has come down after the
According
awareness.
to my results, it's actually increasing.
Increasing. So people lose or people not believe psychiatry. They don't want to come. Even though they know the abnormal behavior is disturbing them, they don't come for treatment. Okay. Anybody from the floor?
I think abnormal is becoming the new normal. So they don't think it is abnormal for some reason. Could be the COVID also. A factor, yes. But you have done it only based on the previous records, no?
Yes, sir.
So who entered the case sheets, how
up to
accurate
2020
was the
done.
entries, we do not know.
Yes, sir.
Okay, Gurumurthy. Long first.
What is the rationale choosing the arbitrary year 2000, before 2000 and after 2000?
I wanted to see for the last 20 years, sir. That's there is no.
You have separated it as before 2000 and after 2000. You have compared it between these two.
Yes, sir.
What is the rationale?
Rationale is to compare both centuries before, from 1990 to 2000 and 2000 to 2000.
Anybody else? Right. Thank you, Doctor.
Thank you.
Thank you, Dr. Nivedita. The next presenter is Dr. Lavina.
Good afternoon, sir. Good afternoon, all. I'm Dr. Lavina from Stanley Medical College. Today, I'm presenting a case report. It's an erratic phenomenon and a dramatic outcome. A case report of phenytoin toxicity presented as dissociative disorder. Phenytoin is commonly used as an anti-epileptic medication. It is used for generalized tonic-clonic and complex partial seizure. Moreover, the usual dramatic neurological cognitive adverse effects can be more troublesome in younger, physically active cases, and those patients with active cognitive lifestyles, resulting in a variety of problems ranging from poor performance in studies to impairment in workplace. Phenytoin-related toxicities was misdiagnosed as dissociative disorder and referred to psychiatry outpatient department. A 24-year-old female accompanied by her mother in psychiatry outpatient department presented with decreased communication, decreased activity, refused to take food, general weakness. Further questioning revealed that she had previously been diagnosed with generalized tonic-clonic seizure, had been phenytoin 150 mg per day with folic acid 5 mg per day for the past 10 years. Was seizure-free and stable on treatment. However, following 2 recent episodes in day before 3 weeks, phenytoin had been increased to 300 mg. She was admitted in psychiatry ward and she underwent basic investigation and the CT brain which was found to be normal. Later, she developed headache, vomiting, difficulty in walking, refused to take food, was increased. On examination, patient had an horizontal nystagmus, ataxia present, and after detailed evaluation, she was suspected for phenytoin toxicity, and after the blood report of serum phenytoin level was found to be 45.8, which indicates a severe phenytoin toxicity. So the phenytoin drug was stopped, neuro opinion was obtained, and tablet levetiracetam was started. Significantly, after stopping offending drug, the patient was symptomatically improved. So the conclusion of this case study is, initially this case was presented as was dramatic in nature, hence treating physicians were misled into the considering the possibility of dissociative disorder. However, careful history taking and supporting scientific evidence rule out such disorder. This case highlights the adverse drug reactions of phenytoin and misdiagnosed as a psychotic disorder, and people who are taking phenytoin need a regular monitoring for long-term basis. The dissociative disorder can be a misleading diagnosis in many situations. In the past, up to 30% of patients diagnosed with conversion symptoms were subsequently discovered to have misdiagnosed organic illness. This are my reference. Thank you, sir.
What was the dissociative symptom?
Sir, actually, we didn't say she had a decreased communication, sir. She never talked to anybody. She was bedridden. She just doesn't want to walk anywhere, and she refused to take food. And even speech was she was refused to take her self care was very poor.
So what was that condition? Whether it was a neurological symptom or a cardiological?
Sir, actually, before she was very fine. After the phenytoin dose was increased, first she was take for 150 milligram, and it was increased for 300 milligram. Her body weight was 35 kg only. So due to this, the phenytoin toxicity. It was found like that, but they just thought it was a psychotic disorder, and they told it's a dissociation. But we admitted the case, and after the evaluation, we did phenytoin. We suspect a phenytoin toxicity, and after phenytoin serum level found out very high, we just stopped the drug, and neuro opinion was obtained. After that, the patient was symptomically improved.
What is the dissociative symptom? See, whether it was conversion as such with withdrawn mutism or any other thing.
Yes, sir, there was a mutism present, sir.
Who diagnosed dissociation in this case?
Sir, from medicine department they referred, sir.
Medicine, so they are unaware about psychiatric conditions. Okay, anybody from the floor? Any questions? Okay, thank you.
Thank you, sir.
I think as per instructions given to us, this may be the last presentation. This is the 15th presentation. So I call the last.
We call upon the next presenter, Dr.
Yes.
Sri Kritika. Kind announcement, those who are presenting free papers, you can check with the AV people here, because your name with your the topic should be available here. We can't do any last minute insertions, so hope you understand.
Yes, you can start.
Good afternoon to one and all present here. I am here to present my research paper on a cross-sectional study of nicotine dependence among psychiatric inmates in a tertiary care hospital. Introduction. Tobacco use is a common pattern of behavior among psychiatric inpatients, and it is an important modifiable risk factor that contributes to medical morbidity and mortality, and it is the least addressed and most underrated menace in psychiatric patients. The psychoactive substance in tobacco is nicotine, which is an agonist at nicotinol acetylcholine receptors. The alpha-4 beta-2 nicotinic receptors mediates nicotine dependence, and the alpha-7 receptor is responsible for sensory gating, which is reduced in schizophrenia, and this explains the self-medication hypothesis by nicotine. And hence it is necessary to address the comorbid tobacco use because of its association with poorer clinical and treatment outcomes. These are some of the common forms of smoking tobacco and smokeless tobacco products used. As per studies, schizophrenia, the tobacco use is twice higher than the general population, and the tobacco users have higher rates of depression than the non-smokers, and in depression there is greater difficulty in quitting. And hydrocarbons in tobacco products is a powerful enzyme inducer, and hence high doses are needed to achieve plasma levels. And according to studies, the blood levels of neuroleptics like flufenazine and haloperidol are lowered up to 50% due to nicotine dependence. Aim and objective of the study to estimate the prevalence of nicotine dependence among male and female psychiatric inpatients, and to determine the clinical correlates of nicotine dependence among various psychiatric illnesses. Materials and methodology. The study was conducted in Tirunelveli Medical College Hospital after obtaining the ethical committee approval for the research. Study population, male and female psychiatric inpatients above 18 years of age with history of tobacco use and who fulfill the ICD-10 criteria for schizophrenia, bipolar affective disorder, depression, anxiety, and stress-related somatoform disorders were taken up for the study. Study design, it is a cross-sectional study. The tools used were semi-structured proforma for collecting socio-demographic details and pattern of tobacco use. And Fagerström test for nicotine dependence is used, and Fagerström test for nicotine dependence for smokeless tobacco is also used. Moving to the results and analysis, this table shows the population characteristics, and out of 106 samples, majority of samples, that is 74.6% belong to the age group 29 to 48 years, and 88.7% were males, and 11.3% were females, and 47% of the samples were unemployed, and majority of the samples were having schizophrenia and bipolar affective disorders, and about 13% have anxiety, stress-related and somatoform disorders, and 11% have repressive disorders. And about half of the samples were having illness more than 5 years. This table shows the Fagerström nicotine dependence scores, and based on the analysis, the prevalence of high nicotine dependence among psychiatric inpatients is 22.6%, and medium nicotine dependence is 51.9%, and low nicotine dependence is 23.6%. This table shows the correlation between gender and level of nicotine dependence, and based on the analysis, there is a significant association between gender and high nicotine dependence, with male psychiatric patients having higher nicotine dependence with a significant p-value. This table shows the correlation between type of primary psychiatric illness and nicotine dependence, and there is a significant association between the type of primary psychiatric illness and the nicotine dependence, with schizophrenic patients having high nicotine dependence with a significant p-value. This bar diagram shows the correlation between increased tobacco use after psychiatric illness and nicotine dependence, and 36.6% of samples with high nicotine dependence has increased tobacco use after illness who had onset of tobacco use before the illness. This pie chart shows the reasons for increased tobacco use. 26.8% have used it to reduce delusion and hallucinations, and 22% have used it to reduce to alleviate low mood, and 14.6% have used it because of tolerance. This table shows a correlation between onset of tobacco use and nicotine dependence, and the results showed significant association between high nicotine dependence and onset of tobacco use, in which patients having high nicotine dependence had onset of tobacco use before the psychiatric illness. And the results showed significant association between duration and high nicotine dependence, with 35% samples with high nicotine dependence used tobacco more than 5 years. And there is a significant association between attempt to quit tobacco and high dependence, and they have a failed attempt to quit tobacco. And there is a significant association between age of onset of tobacco use and high nicotine dependence, with high nicotine dependence had used tobacco before 18 years of age. Coming to the discussion part, patients with primary psychiatric illnesses have comorbid medium and high nicotine dependence. Similar findings were reported by Prabhas Chandra et al. Medium and high nicotine dependence is more among patients with schizophrenia. Similar finding reported by John Lallian et al. Patients with bipolar affective disorder has medium nicotine dependence, and similar findings were reported by N. Breslov et al. Patients with high nicotine dependence have increased tobacco use after psychiatric illness. Contrary findings reported by Prabhas et al. And male psychiatric patients have high nicotine dependence than females, and similar findings were reported in a study. And psychiatric patients who were using tobacco previously has increased usage of tobacco products after onset of illness. And patients with medium and high nicotine dependence have more failed attempts to quit tobacco use. Conclusion of the study, prevalence on medium and high nicotine dependence is more among psychiatric inpatients. Patients who are nicotine dependent have multiple failed attempts to quit tobacco, and hence smoking cessation regimen should be implemented in wards along with the management of psychiatric disorders to improve clinical outcome in patients. And tobacco cessation intervention should be advocated to replace potentially dangerous self-medication by nicotine with safer and more effective medications to reduce medical morbidity and mortality due to nicotine dependence. These are my references, and thank you for the opportunity.
Thank you, Dr. Sri Kritika. Regarding this dependence, I can cite a paper which was presented in our TANPSYCON long ago by a student saying that he said in the conclusion, by using tobacco, he can get rid of the symptoms. He just erroneously concluded. As long ago, it happened 10 years ago. I was there during the session. And one thing regarding nicotine, you have to be very clear. Either smoking and taking a medicine, or taking a medicine and smoking after some time, both impair drug absorption as well as the availability, bioavailability. That should be made very clear. Not only psychiatric drug, most of the drugs. Most of the drugs. So this availability also has to be curtailed, nicotine. So treating a patient for psychiatric illness and treatment for tobacco cessation is a very difficult thing. Both cannot go hand in hand, because you know the what the varenicline will do and other things. You have to be very cautious. Any questions from the floor? We have one more paper. So any questions from the floor? Yes.
Anybody else? Thank you, doctor.
Thank you.
Thank you for your good presentation. We have one last presentation.
இல்லையா அங்கே போயிட்டாங்களா போஸ்ட் போயிட்டாங்களா
Sabri?
Anybody coming?
இல்ல,
வரட்டும் will give. என்ன அடுத்த 9 தானே வரட்டும். இல்லை அங்கே வந்து டைரெக்டாக ப்ரெசென்ட் பண்ண வேண்டியது.
So the next presenter is Dr. Kavya, the last presentation. Those who are going to present tomorrow, it will be informed in the group. We may start from 8 itself, 8 to 9, and then from 10. We will start from 8. So in the group, we will notify the candidates who are going to present at 8, okay?
Good evening, I'm Dr. Kavya from Mahatma Gandhi College. Today I'll be presenting my study on a study of sleep-related cognitions and behaviors among patients with anxiety and depression attending psychiatry outpatient services in tertiary care hospital. So insomnia is a common clinical condition which is characterized by persistent difficulty in initiating or maintaining sleep, and it has a strong association with psychiatric disorders with prevalence of up to 50%. And it is the most common symptom presented in anxiety and depression disorders, and usually the prevalence is of about 20 to 40% with a bidirectional relationship between the anxiety and depression, where anxiety and depression can lead to insomnia, and insomnia can further worsen anxiety and depression. And according to cognitive model of insomnia, which was given by Harvey, it says that patients with insomnia have excessive worry and distorted beliefs about sleep, and this leads them to engage in counterproductive safety behaviors, which can further exacerbate insomnia. And these sleep-related cognitions play an important role in maintaining insomnia, and there has been little research on these studies on these aspects with various psychiatric disorders. And there are very few Indian studies regarding this dysfunctional beliefs and attitudes about sleep. And there is a need for study of these sleep-related cognitions and behaviors, their influence on insomnia in relation to anxiety and depression. And hence the study was taken. And this was a cross-sectional observational study which was done on patients who were diagnosed with anxiety or depressive disorder based on DSM-5 criteria. And these were the inclusion and exclusion criteria. Methods, like initially patients diagnosed with anxiety and depressive disorders, they were administered the following scales. That was HAM-A, MADRS, and Insomnia Severity Index to assess the severity of anxiety, depression, and insomnia. And on the other side, age and gender related healthy controls were administered the same scales to rule out all these disorders. And then they were administered Pittsburgh Sleep Quality Index, dysfunctional beliefs and attitude about scale, pre-sleep arousal thoughts, and sleep-related behavior questionnaires. And further, a subgroup analysis was done on the same cases where they were categorized into two groups, that is anxiety and depression who were having insomnia, and the other group was anxiety and depression without insomnia. And again, we saw the differences in these dysfunctional beliefs and behaviors among these two groups. So coming to the results, among the distribution of socio-demographic variables among cases and controls, so majority in this study were females who were married and education status of up to high school, and then a majority of them from lower middle class, from rural background. And similar findings were seen in control as well, and there were no significant differences. And coming to the distribution of illness characters among cases, 38% were diagnosed as generalized anxiety disorder and 28% of depression, and rest were diagnosed under other anxiety disorders. And on comparing the sleep-related cognitions and behaviors between cases and controls, there was significant difference among the cases and control group among all the factors, that was dysfunctional beliefs, sleep-related behaviors, as well as pre-sleep arousal thoughts. Coming to the subgroup analysis, where it was done among the cases group, were categorized to two groups, with insomnia and without insomnia. So again, among these two groups, there were significant differences noted, and the group with insomnia had higher, significantly higher distorted beliefs and behaviors about sleep. Coming to this study, the conclusion, like basically these distorted beliefs and about cognitions and behaviors, they can independently influence insomnia apart from anxiety and depression. So it is considering the major role of cognitive behavioral therapy in treatment of insomnia, it is important to address these factors and manage them, which may help in alleviating the insomnia in patients with anxiety and depression. So these are my references. Thank you.
Any questions from the floor? We have time. What are the cognitions, sleep-related cognitive disturbances?
Basically, the dysfunctional beliefs and attitudes they have towards the sleep. So initially they tell if today they are not able to sleep, then they are not going to have sleep for tomorrow.
So cognitive distortions regarding sleep.
Yes, sir.
So I thought sleep-related cognitions means patients, when they are getting into sleep, they may have some cognitive disturbance or other things. This cognitive distortions are cognitive beliefs regarding
distortions
sleep.
And secondary behaviors regarding the sleep.
If there are no questions, we will wind up today's free paper session. We have 9 more papers running short of time. 2 hours, exactly 2 hours. We have finished 16 papers. It's the right time. I thank you, the presenters. They have to be showing more and more interest and more specific towards their presentation. They have to use standardized scales, and they can, many were new, this size 0, this infertility, psychological trauma, and MI. Many things were new, DUP, phenotypic toxicity, and many are time-tested topics. And my sincere request is, do not tackle or meddle with social factors in your studies. Always go for a scientific new findings. You may be the first one to present a finding that you can have the name. If all your findings are replicated in future studies, you will be the luckiest person. So, and in presentation also, you have to be more specific. Don't be meddling with, or don't be dilly-dallying with this initial introduction. Just you have to be very crisp and go and spend more time in the results and the discussion. That will be more appealing to the listeners or as judges.
And please practice at home so that you stick to the timing. Because if you cross your timing, that leaves a bad impression. Even though the paper might be good, if you keep dragging on, and correct your slides with your seniors so that there are no spelling mistakes, grammatical errors and all that. So many of the slides, we felt that you could have got the help from somebody. Okay, so next time you present, make sure the presentations are clear, like you said, and correct. Thank you very much. Thanks for the opportunity.
Thank you, chairpersons. It's time to honor our chairpersons. I request Dr. Sabrin to honor our chairperson, Dr. Deep. Thank you, sir. I request Dr. Ganesh Kumar to honor our chairperson, Dr. Kumanan, sir.